25.
24, yalla. Bismillah.
Thank you very much, Mr. Chairman. Good afternoon, ladies and gentlemen. It gives me great pleasure to present the topic, the image-guided PCI, new insights from OCT recent clinical trial, touching upon the recent trial presented in the European Society of Cardiology in Amsterdam last August and TCT last month in the San Francisco, United States. So we'll start with the Element Fall trial presented in European Societies 27th of August by Ziad Ali. And this trial is OCT versus angiography-guided PCI, which published simultaneously in New England Journal of Medicine in August 2023. We know that Element 3 trial showed that OCT guidance improved procedural success compared with angiography guidance in its sense of greater stent expansion, reduced major malapposition and major dissection, but the improved clinical outcome was not addressed where the Element Fall trial was addressing the clinical outcome. They randomized 2,487 patients into OCT-guided PCI versus angiography-guided PCI. And they tested for the high-risk patient as well as high-risk lesion in 1:1 randomization. In OCT guidance, the OCT implanted a specific protocol pre and post procedure. And they tested three primary endpoints, which is the primary imaging endpoint, and this is powered for post-PCI minimum stent area. The second primary is a clinical primary endpoint, is the target vessel failure during 2 years follow-up. And last is the safety endpoint, which is not powered, addressing the stent thrombosis and procedural complication. They recruit a high-risk patient, medication-treated diabetes, and high-risk lesion. And diabetes contributed more than 42%, and acute coronary syndrome around 59%. In the OCT arm, the long or multiple lesions were higher in percentage compared to the angio arm, and the calcification, severe one, is higher in OCT, as well as lesion length is longer in OCT arm compared with the angiography arm. As well as the procedural duration is longer, and fluoroscopy duration and contrast volume were higher in OCT compared with angiography arm. So this is, ladies and gentlemen, the primary imaging endpoint, which is the final post-PCI minimal stent area. In OCT was 5.72 millimeters squared versus 5.36 in the angio arm. A difference is 0.36, which reach a high statistical p-value. And for the stent expansion, the mean stent expansion is higher in the terms of percentage in OCT arm, as well as acceptable mortality is also higher in OCT compared with the angiography arm. The major dissection was lower in OCT compared with the angio, as well as the malapposition. The major one is less, 15.8% in the OCT arm compared to 33.2% in the angio arm. The tissue protrusion, the major one, was less in the OCT arm compared with the angio arm. And for reference disease, the focal lesion is less in the OCT arm versus the angio arm. For the angiographic complication, the procedure-related thrombotic events lower in OCT arm compared with the angio arm. And for the primary clinical endpoint, which is target vessel failure, in OCT arm was 7.4% versus 8.2% in angio arm, numerically lower, but not reaching the statistical significance, with the hazard ratio is 0.90 and p-value is 0.45. Now, the cardiac death was numerically lower, again, did not reach statistical significance, as well as target vessel MI was numerically lower, 2.5% versus 3.3%, not reaching the statistical significant. And the ischemia-driven target vessel revascularization were comparable in each arm, 5.6, again, not reaching the statistical significant. Stent thrombosis, although was not powered, but showed a significant reduction in the OCT guided, 0.5 versus 1.4, with the hazard ratio of 0.36 and p-value is significant, and knowing that the death or MI within 2 years occurred in 95% with a stent thrombosis. This is the summary of all clinical outcomes summarized in this table that I explained to you. Of course, in the COVID has an impact on the trial results. As you can see on the left side, the pre-COVID period, the OCTR was 7.2 versus 10.1. There was separation of the curve, but during the covered period, they are overlapping each other. So the conclusion, Mr. Chairman, dear colleague, for the first trial is the OCT guidance resulted in a larger minimum stent area than the angiography guidance with a greater stent expansion. The OCT guidance lead to fewer major dissection, major malapposition, major tissue protrusion, and untreated focal reference segment disease. And the OCT guidance reduced the angiographic complication. The 2-year rates of target vessel failure were not statistically different between two arms, and the OCT guidance significantly reduced the stent thrombosis. There were trend to the fewer cardiac death and MI, but they did not reach in the statistical significant. Last month in October in San Francisco, they did a subgroup analysis. It's called OCT imaging predictor of clinical outcome. And the aim of this is to drive what are the OCT imaging derived parameters that they may predict adverse clinical outcome, and they examine these predictor clinical outcome. And they link to the 4 primary clinical endpoint. The first one is target lesion failure. The second is cardiac death or target vessel MI. The third, ischemia-driven target lesion revascularization. And the last is the stent thrombosis. From the total cohort in Illuminal 4, which is 2,487, they could analyze the data in OCT-guided PCI of 1,056, and in the angiographic arm is 1,072 patients. The baseline characteristics is no change from the entire Illuminal 4, higher percentage of diabetes as well as acute coronary syndrome. The long or multiple lesions higher in the OCT guidance, as well as the advanced lesion preparation, total stent length, maximum stent diameters, and post-dilatation balloon are all higher in the OCT arm versus the angiography guidance. For the minimum stent area, as well as higher in the OCT arm versus the angiography guidance, and the minimum stent expansion is higher in the OCT guidance versus the angiography arm. For the focal lesion is lower in the OCT arm, and the dissection, the major one, is less percentage in the angiography versus OCT arm. The clinical endpoint, no differences as in the Illuminal 4. They only notice the stent thrombosis is 0.4% versus 1.3, and this is statistically significant by p-value 0.2. Now, this is important table of this subgroup analysis when they link the OCT parameters with the 4 clinical outcome. They show that the target lesion failure is affected by minimum stent area as well as proximal edge dissection. In a sense, the lower in a minimum stent area, the higher the target lesion failure, the more the proximal edge dissection, the higher the target lesion failure. And this also applies for the stent length. The longer the stent length, the more the target depth or target vessel MI. And for stent thrombosis, the minimum stent expansion, the below the minimum stent expansion, the higher the stent thrombosis, and the higher the stent expansion, the less the stent thrombosis. And if we apply this to penalized SIP-line analysis, in the green is 2 years target lesion failure, the purple hazard ratio. You can see that when the y-axis target lesion failure, the minimum stent area when it comes 5 and above, lower in target lesion failure. However, when it comes below 4, there is an exponential increase in the target lesion failure. And for the distribution of the bar, similar, when the minimum stent area below 4, there is an exponential increase in the target lesion failure. So the conclusion of this subgroup analysis, ladies and gentlemen, that in the Aluminum 4 trial, the most important OCT drive post drug-eluting stent predictors of both safety and effectiveness outcome were parameters related to the stent area, stent expansion, stent flow, proximal edge dissection, and stent length. And the conclusion is that optimizing these parameters with OCT guidance may improve the drug-eluting stent outcome. Then the October trial, ladies and gentlemen, presented again in European Society of Cardiology in August, in August 2023, and published simultaneously in New England Journal. And the background of this is that the OCT required for procedural optimization, as it showed better stent expansion, reduced stent malposition, and better scaffolding of the side branch stent. So the aim of this trial is to evaluate if routine stepwise guiding by OCT improve clinical outcome after PCI in a true bifurcation lesion compared with the angiography-guided PCI. 1,200 patients randomized in 1:1 to OCT guided versus angiographic guided, testing the primary endpoint MACE at median 2 years. And it's a European label, 300 centers in Europe, open label design, mainly in Europe. These are inclusion criteria, clinical. On the right side is the angiographic criteria. Beside the primary endpoint MACE, they also had secondary endpoint, which is individual component of MACE, as well as patient-oriented composite endpoint, which is all causes mortality, any MI, any coronary vascularization or stroke, and finally, all causes mortality. They did what is called OCT protocol, and this is one of the strengths of the trial. Before stent implantation, they did OCT after rewiring and final evaluation. As well as they have objective for OCT protocol for doing OCT for optimum lesion coverage, optimum stent expansion, no stent malposition, and no unintended crush or distorted stent segments. And they did this design dedicated protocol, which give us the results. For the angiographic guided group, OCT was not allowed. IVUS was not encouraged, is only allowed in left main lesion in about 15% of the cases in the left main. The baseline characteristic, majority were stable angina, 55, followed by non-stable angina. Left main is only around less than 19%. Majority of bifurcation is LAD, 70%. And the total stent length in the major vessel is higher or longer in the stent arm. And the procedural characteristics, as in the luminal trial, the total contrast time, procedural time, fluoroscopy were all higher in the OCT arm versus in the angiography arm. So the primary endpoint, Mr. Chairman, the MACE was 10.1 in OCT guided PCI versus 14.1 in the angiographic guided PCI, with hazard ratio of 0.70, reaching relative risk reduction of 30% with a statistical p-value of 0.035. Now, for the patient-oriented composite endpoint, was numerically lower in the angiographic, in the OCT arm, 13.6 versus 17.7, but did not reach statistical significance, as well as all-causes mortality, numerically lower, 2.4% in OCT-guided versus 4% in angiographic-guided, and again, not reaching the statistical significance. The cardiac death is 1.4%, numerically lower in the OCT-guided PCI versus 2.6 in angiographic, again, did not reach statistical significance, and target lesion myocardial infarction, numerically lower and not reaching statistical significance, as well as ischemia-driven target lesion revascularization, numerically lower, not reaching statistical significance. Now, when you have the primary endpoint with a subgroup analysis, overall no changes, although one stent did better with OCT versus 2 stent, but the P interaction was not significant, so overall no interaction in the subgroup analysis, as well as in the anatomical lesion, no differences between the two arms in the subgroup analysis. Procedural safety, complications were comparable in both arms, and procedure-related MI also were numerically less in the OCT arm versus the angiographic arm. The limitation of this, ladies and gentlemen, is that the physician-patient not blinded to allocated treatment. The COVID, as in element 4, delayed the enrollment, and they cannot exclude that the pandemic had an effect on the trial. Last but not least limitation, the IVAS was used 15 angiographic guided cases for left main. Whether this has affected the results also is one of the limitations. So the conclusion of this trial is the OCT guided PCI was associated with a lower incidence of the composite endpoint of 2-year MACE than angiography guided PCI in treatment of complex bifurcation lesion, and no interaction were identified. As I mentioned, procedural safety did not differ, and procedure time, fluoroscopy time, contrast volume were all increased in OCT guided PCI, but this has not impacted in increasing in contrast-induced nephropathy. Then last month in TCT in San Francisco, they did subgroup analysis to discuss the patterns in stent failure after bifurcation PCI, and what is the aim is to characterize the lesion distribution in stent failure cases after bifurcation PCI in October trial. They analyzed the data, and they took the 40 cases with target bifurcation revascularization with median of 2 years, and they identified, ladies and gentlemen, that the restenosis was higher in the side branch, about 60% in OCT guided, also higher in the angiographic guided. For the left main, the restenosis in the ostium with the circ was high in the both arms, but highest in OCT guided. And for the post-PCI characteristic of corresponding segments was limited. And of note on the box, 13 of 16 cases of OCT arm did not have a good or better results at the final OCT. And of course, the restenosis, the 2 stent, higher restenosis rate, 80%, versus the 1 stent is 20%. And this higher stenosis increasing the procedural time as well as fluoroscopy time in the restenosis compared to no restenosis. So the conclusion, ladies and gentlemen, from this subgroup analysis, that the target bifurcation restenosis was located to the side branch in about 60% of cases in both treatment groups. The circumflex ostium was the most frequent location for instant restenosis after left main bifurcation in PCI, both groups. 13 of 16 cases with instant restenosis in OCT guided group had no OCT guided or poor final results by the OCT at the baseline. And this also, the meta-analysis was also discussed in European Society of Cardiology in 2023 and presented by Greg Stone using the October trial and Terminal 4 trial. They were included in this meta-analysis. However, the Octavius trial was not included in this meta-analysis. they use the Prisma guidance as the method 1. And for the method 2, they use a pre-specified primary comparison of intravascular imaging guided both OCT or IVUS against angiography. And then also they use IVUS guided versus OCT guided, testing the primary clinical endpoint, target lesion failure, and the secondary endpoint, the component of target lesion failure. Included 20 randomized trial, and in the nodal map, these are the names of the trial and number of the trial of the each arm analyzed, ladies and gentlemen. For the target lesion failure, the relative risk reduction, the relative risk is 0.069, leaving relative risk reduction of 31% with highly statistical p-value, and the I2 for heterogeneity is 0%, and for the cardiac death, the relative risk is 0.54 with high statistical p-value, and the heterogeneity is 0%, and all causes death, relative risk is 0.75 with relative risk reduction 25%, again significant p-value. Target vessel MI, relative risk is 0.80 with relative risk reduction 20% with significant p-value, and the heterogeneity is 0. All MI, relative risk reduction 18% with significant p-value 0.003, and for stent thrombosis, a significant reduction of 52% with significant p-value. And for target lesion revascularization is 29% relative risk reduction with significant p-value. And this is the summary table of all the outcome that I have mentioned. And when they did the OCT PCI versus IVUS guided PCI, they did not show any differences in these two arms. And they used two types of analysis, the Pearson meta-analysis and frequentist meta-analysis, and they were comparable in showing the results, no differences between these two analyses. Of course, the limitation that the Octavis was not in this analysis, and therefore the comparison between OCT and IVUS was limited, and the results did not show any difference in this meta-analysis. So the conclusion, ladies and gentlemen, the present meta-analysis from 20 randomized trial showing that compared with angiography-guided PCI, intravascular imaging-guided PCI with OCT or IVUS reduces target lesion failure by 31% with significant p-value, and this is driven mainly by 46% reduction in cardiac death, 20% reduction in target vessel MI, and 29% reduction in target lesion revascularization. Intravascular imaging guided PCI reduces stent thrombosis by 52%, all MI by 18%, and all mortality by 25%, and these all are significant p-value. The outcomes for analysis between OCT guided and IVUS were similar without any differences. For the limitation, the implication of this is not moving the slide. For the implication of this, okay. For the implication of this, ladies and gentlemen, there are some additional points need to be addressed in the future. Which lesion type must benefit from intravascular imaging guidance, and the optimal technique and procedural objective needs to be addressed in the future. Last 1 minute for Octavis trial that presented in European Society 23, it's last minute. This has been presented in the European Society in Amsterdam, published in Circulation. The hypothesis is that the OCT guided PCI is non-inferior to IVUS guided PCI with respect to target vessel failure at 1 year. And this is the design, taking 1,000 in each arm, and they tested the composite endpoint of target vessel failure and the secondary component listed here, individual component. And the primary endpoint of target vessel failure met the non-inferiority as p-value for non-inferiority significant, with numerically lower in OCT guided 2.5 versus 3.1, with hazard ratio of 0.80, relative risk reduction of 20, but not reaching the statistical significance as the difference, but it met the non-inferiority. For pre-specified subgroup analysis by clinical factor, as you can see, no differences between OCT-guided PCI or IVUS-guided PCI, as well as anatomical factors, no differences between these two arms. And the summary, Mr. Chairman, that the OCT-guided PCI was non-inferior to IVUS-guided PCI with respect to the primary endpoint of target vessel failure at 1 year, and the amount of contrast used was higher in OCT than in IVUS, but this was not related to an increase in contrast-induced nephropathy. By this, I end up the whole trial that I presented, and thank you very much for your attention.
Thank you very much.